Hi, everybody. Welcome to another virtual morning report. We start off with just a public thank you to Patricia and Marisa for doing our teaching points and scribing. And Vinicius has been coming to us with a flurry of cases lately, and they've all been very exciting and complicated. So I am excited to hear what we have in store and perhaps be relying on some insight from our chat, depending on how things go here. So yeah, I'm excited and ready to take it away when everyone else is.
Yeah, how are you, John? Hope everything's good. I'm really excited to be here today along with John. And this is the first time I'm going to be discussing. Actually, John's presented many cases, so it's nice to have him on this side discussing a case. So very excited to share and learn for another
Yeah.
Vinny special. Um, Vinny's presented so many challenging cases and has taught us a lot. So I'm really happy to at least be receiving another case from him today, and I really appreciate him spending the time to put a case together. And then we also have Patricia and Parisa who'll be doing scribing and teaching points. And without them, we cannot do this work. So I really appreciate the both of you as well. Vinny, you want to unmute and just say a few words?
Yeah. So, hey everybody, I'm Vini. I'm a medical student from Brazil, and I'm very excited for today's presentation. Should I begin?
Yep, let's go.
Yeah. All right. So for the first aliquot, the chief complaint is general malaise and edema for 4 months. I'll stop here.
All right. You want me to tackle the first one, Ravi?
Yep, thank you.
Okay. All right. So like coming in with a pretty non-specific, chief concern or concerns. With malaise, it could mean a lot of different things. I'm looking for something else to put my clinical reasoning hat on. The edema for 4 months, the time course is a valuable piece of information. And some of my general process for edema, some clues I'll be looking for to make progress is kind of the slope of the progression and whether it's symmetrical or not. If it's symmetrical, kind of can break it down into problem with hydrostatic pressure, too much hydrostatic pressure from some type of obstruction or cardiac process. Or you could have decreased oncotic pressure related to something like a nephrotic syndrome, liver disease, protein losing enteropathy, or if I've been fooled by something of the skin and soft tissue before. Somebody just has something with the underlying fascia. So it's pretty broad, but I think those are some of the key clues I'll be looking for to make progress and looking for see if there's any signature of some kind of systemic disease.
Yeah, I really like your start and your pragmatic approach to this. And I think at this point, the malaise, I think, probably is non-specific. I mean, malaise could be interpreted many different ways, but at this point, I don't want to expend too much cognitive energy if it really doesn't help me get to the solution as quickly as possible. So it could end to a diagnostic dead end. But the edema, I think, is definitely valid. 4 months. I mean, by 4 months, edema, I mean, I usually reflexively type 1 thinking equate edema with hypoalbuminemia or a hydrostatic or increase in hydrostatic pressure. So oncotic versus hydrostatic pressure, which one of the balance of this is primarily causing this? And then where exactly are you having the edema? Is this anasarca where you're just like so swollen from head to toe, or is this in the lower extremities? So we haven't gotten that information, but that will be very vital to try to solve this case today. So anything else, John, before we swing it back to Vinny?
Yeah, I think like when you get this kind of chief concern, sometimes it's important to just not forget to just let the patient talk for a little bit. As much as you have time, they'll think of things that you don't think to specifically ask before you go right to the jugular and ask questions that might suggest some chronic liver disease or chronic kidney disease. But those would be what I'd be really looking for to make progress.
Right. So perfect. So for the second aliquot, we have a 74-year-old female that reports that is seeking medical care due to a back pain and intense pain in the upper limbs, which began about 4 months ago and has progressively worsened. And additionally, she complained of poor appetite, weight loss, generalized edema. So at times the edema was in the upper limbs, and other time was in the lower limbs, and also a frothy urine. Besides, in the outpatient setting, the patient did a test that showed altered kidney function, prompting referral for our service for further investigation. So she denied like fever, infections, and other things. About the past medical history, the patient has hypertension, heart failure with reduced ejection fraction, hypothyroidism, history of like I said, a trending like creatinine that is under investigation, and a cervical mass under investigation for 5 months. So all that I said before, the pain in the upper limbs is related to cervical symptoms. She also has a breast cancer 30 years ago that was treated with surgery, chemotherapy, and radiotherapy. She does not have any surgeries, denies smoking and alcohol use. About his meds, she's taken atenolol, enalapril, spironolactone, furosemide, levothyroxine. Yeah, that's it. I'll stop here. So just to do a summary, we have a elderly female patient that presented with upper limb pain and generalized symptoms, with poor appetite, weight loss, edema, and came to our service to investigate an uptrend in creatinine.
I guess I'll start here. So I think we kind of have a pivotal point. The kidney is mentioned. So kidney and proteinuria. What was very interesting, you mentioned the patient had frothy urine, right, Vinny? I think it hasn't
Yeah,
been.
that's right.
Right. So this is interesting. I've had patients come and they'll say, yeah, my urine is very bubbly. But I looked this up, and we always equate like frothy, bubbly urine to be indicative of proteinuria. But what's interesting, sometimes cleaning products in the toilet bowl can actually react and cause frothiness. So that could be a sort of pseudo proteinuria kind of state. Diabetes is also known to cause frothy urine as well. Fast urine stream could do it too, as the urine stream vigorously perturbs the surface of the water in the toilet. It can actually induce bubbles and frothiness, but that usually dissipates very quickly. It doesn't hang around and just obscure the surface of the water in the toilet bowl. And then I think also dehydration could cause it, and then comes what we're interested in is kidney disease. So definitely this would reflexively send us down the testing to get urine, and then also especially look at the urine electrolytes and also the kidney parameters. And also I would do a quick POCUS of the kidneys to see if there's any anatomical abnormalities, any post-obstructive features to the urine. And also we want to quantitate the urine as well. So there's a whole slew of different things that we would actually perform to work up the kidney. In addition, the patient has history of heart failure with reduced ejection fraction. And then comes the endocrinological abnormality. So hypothyroidism in itself can cause or is featured in the differential diagnosis for edema. Although more localized, you tend to have this pretibial mixed edema and lower extremity edema that you could have associated with hypothyroidism. But you're describing the patient as having generalized edema. So this would be more in tune with possibly nephrotic, because remember in nephritic syndrome, you can have up to 3.5 grams of protein in the urine, and beyond that would be nephrotic syndrome. But at this juncture, I think definitely the exam may be helpful, and most definitely the labs. But I'll turn it over to John if he has any more insight into this to add to this case.
Yeah, so let me start with saying it's a lot of information, and it can be overwhelming trying to think about what's signal, what's noise, what are you kind of putting most of your emphasis on. And I guess what I'm drawn to, like you, Ravi, is the center of gravity kind of being probably towards the kidneys, with concern for concern for proteinuria, given some of the other clues. But I'm certainly tracking all of these other things, try to solve the problems, list them out individually, try to see where they overlap. If something doesn't fit right away, kind of keep tracking it and don't lose those details. But so I'll be putting my weight on, possibility of nephrotic syndrome and looking for ways to overlap with some of these other features. Vinny, when you said cervical mass, did you mean like cervical spine or like cervix in the pelvis?
Yeah, so great discussion so far. Just to clarify, the patient, we had like a similar approach. We was thinking about different problems that the patient had. And now answering your question specifically, the patient like had some mass in the inferior cervical region, but also when you move the neck of the patient, and it's not like a Babinski sign, nothing like that. But when you move when you move the neck of the patient, she feels like some shock-like sensation in the upper right limb. That's it. So we have like, even though when we think about when we try to separate the problems and we try to think just on the neck about the problem of the neck, we have like two problems. So we have a mass and the neurological thing.
And when I hear of this kind of like electric sensation with movements of the neck, kind of the reflexive thoughts, it's like you have like atlantoaxial instability, some kind of, inflammatory process in the spine, or the like Lermite sign with like a demyelinating process. But we're not really seeing clues for either of those things. So I'm still not quite sure what to do with this, how to link it together. But this background of malignancy with concern for pointing us potentially in this potential nephrotic syndrome, there's probably going to be a way for us to link these together once we get some more data. And some definitely things I'll be looking for to make progress is some imaging to better understand the space in the neck. And I want a urinalysis and urine protein pretty badly.
Right. So can I go?
Yeah, go.
For the physical exam, we have a patient that is in regular general condition, that is pale, a little bit pale, but well hydrated. The blood pressure is normal. The heart rate is 85. The oxygen saturation is 96%. The respiratory exam was pretty normal. The cardiovascular exam was pretty normal also. The neck, already described it. And about the extremities, so the patient feels like a hyperalgesia sensation in the right hand, and also loss of strength in that limb. So we can categorize like the muscular strength of maybe 4 out of 5. And also I think that's it. We also have a edema that is 2 plus out of 4 in the both upper and lower limbs, and then that is non-elastic and painful on palpation, and basically that. The laboratory test I'll send them in the chat here. Give me a minute. Yeah, so that's a lot. So the most pertinent ones is the creatinine is 6, with a high BUN. the potassium that is decreased as 3.2, sodium is decreased at 130, hemoglobin of 6, and hematocrit of 21. Leukocytes is also decreased at 3,800. Platelets also decreased at 44,000. A high ESR at 100. In ionized calcium that is high. Bilirubin normal. AST is a little bit high at 73. ALT of 22. And TSH of 11. A free T4 of 1. And LDH of 360. And a ferritin of more than 5,000. I'll stop here.
John, I guess we can split labs and exam. Do you wanna try the exam?
Sure. Yeah. A lot of information to digest. So I think like we're reassured that she's not in acute distress. It's kind of in line with some progression of a chronic process with some pretty significant labs. But normal heart rate with a hemoglobin of 6 tells you this didn't just happen overnight or in the last week. This has been kind of a slowly progressing, evolving process. Yeah, with this, the right hand changes. It's kind of making me circle back to whether there's this kind of cervical mass is causing some compressive symptoms, and perhaps could be connected to some of the findings we have in the laboratories too. So you get the more challenging section of the aliquot, Ravi.
Yeah. Yeah, we could split this. I know there's a lot to really chew on here, but before we even get into this, so say this patient is in our care on one of our teams, management reasoning would dictate immediately at least managing the patient and reducing any of the nephrotoxic meds here. So if we scour the list of meds, enalapril, spironolactone, those we would have to be cautious with and also definitely need to hold and discontinue. And in case the patient does have uncontrolled blood pressures, we can enact other sort of meds that could have less interaction with the kidney as well. And both a combination of enalapril, spironolactone, they could actually cause hyperkalemia. The other thing, when you have kidney failure like this, you want to think about, should I urgently call nephrology? So reasons to call nephrology immediately would be, at least if there's an emergency potassium. If potassium is out of order here, though, we have a lower potassium. So if we had an elevated potassium, we definitely would have to go down the management line, get an EKG, immediately administer cardiac protective medications, calcium gluconate or chloride, and then also give medications for transcellular shift, shifting the potassium into the cells, excreting the potassium through the gut or through the kidney, and then watching the potassium. So those would be life-saving measures with elevated potassium. Usually with kidney failure, you definitely would have to address them before you start deciphering the cause of this kidney injury. And then looking through the rest, I think AST is slightly a little elevated than the ALT. So just thinking about AST, is it coming from maybe a hemolysis? Is it coming from alcohol use disorder? It definitely is greater than 2-to-1. Is it coming from certain medicines? Yellow fever can cause it, I think, bromide toxicity and so on. Or I may be confusing that with, I'm confusing it with a anion gap. But in this case, AST, coming from tissues, so rhabdomyolysis, coming from hemolysis. In that case, I would think about it getting released from somewhere. CRP, interestingly, CRP is not terribly elevated, although this patient is massively inflamed, and you can come to that conclusion from just looking at the ferritin. The LDH is mildly elevated, again, some tissue inflammation / destruction somewhere. So LDH again could be expressed from hemolysis, could it be expressed from muscle, could be from injury to the liver, infections of the lung, PJP pneumonia, namely, could do it, and vascular disease and hematological lymphomas and hematological malignancies are the other causes of LDH being elevated. Here, the really interesting thing is the ferritin. What I'm going to do is I'm going to let John, because the exam wasn't that, I guess, forthcoming with ideas what was going on, except this hyperalgesia sensation in the right hand. But I'm going to let John in on some of this to have some fun with the labs.
Cool. Yeah, thanks, Ravi, and great discussion leading off. So I'm going to start highlighting a couple things that some people in the chat have noticed as well. So when you have a profound anemia and your reticulocyte count is quote normal, that's very AB normal. So it's going to end. We've got some other signature of things in the labs that are a little unusual. When somebody has a profound kidney insufficiency, the fact that the potassium is low is a little bit weird. And this is the ferritin being over 5,000, kind of the acute phase reactant marker of inflammation. I've seen some pretty high ferritins from bacteremia, from COVID-19 that's been 4 digits. When I see it above 5,000, it does kind of make me kind of think about the kind of a pattern of inflammation. I'll channel George Santos and say kind of HLH-ish to start, and that look for other signatures of that. And HLH being this kind of fingerprint of inflammation driven by interferon gamma with excessive macrophage activation that can kind of circle back on itself and cause this cytokine storm, usually triggered by some kind of underlying cancer or infection, and get to where the immune system is the thing that's killing you as opposed to whatever triggered it. So I always keep that in mind. You look for splenomegaly. We have the cytopenias. We have the hyperferritinemia, triglycerides, and type 1 reasoning is pointing me towards we have this mass in the neck. Could we, in the hypercalcemia, could we be looking at a lymphoma that in some cases can be a trigger for a nephrotic syndrome? They can also have granulomatous inflammation and cause increased calcium by way of pathologic conversion of vitamin D, the compressive symptoms of the arm, that potentially a trigger for a HLH-ish type of inflammation as well. Now, don't want to anchor on that, but something on my mind, and a lot of still keeping a broad differential with infectious buckets too. And I think the urine will be helpful in the next steps, the neck imaging. And I probably still kind of send off some first pass information for, work up for common causes of the nephrotic syndrome, pending urine and other stuff.
Yeah, John, what's interesting at this juncture, we discussed this mass and then this kidney, and then I'm kind of thinking about, are we going to go down the rabbit hole just the kidney, but should we bring this mass in? So there's a certain number of different conditions that could cause, I think we're pretty much on to the nephrotic syndrome train. And I think that the issue here is, yes, nephrotic syndrome, but what's causing it? So when you look through the different causes, and we're seeing a signal with this solitary lymph node, it's rather interesting what kind of differential we can come up with lymphadenopathy impacting the kidney. We talk about pulmonary renal syndromes. How about lymph node renal syndromes? We never really paired those up together, but I've seen some really stark cases on CPS where things can happen like this. So of course, I think monoclonal gammopathies could be one, definitely in the workup of nephrotic syndrome. You can get lymphadenopathies like this. HIV, I've seen it like this. So HIV is definitely another one. And then hematological malignancies, lymphomas could also cause this as well. Then autoimmune conditions. And you also mentioned granulomatous disease. So certain granulomatous disease definitely has impact on the kidney as well. So it'll be very interesting. We diagnose nephrotic syndrome, but then what about, we're going to have to sort of shine the spotlight on this lymph node to elucidate it. Why is that enlarged and possibly causing this nephrotic syndrome, if that is the case? Back to you, Vinny. Very interesting case so far. Thanks.
So, all right. So just to localize you guys where the team and at what point we are thinking right now. And so by this point, the most concerning feature for us was the past medical history of heart failure and also the edema that was a chronic edema. So thinking about that, we decided to proceed with a echocardiogram, and now came a huge turnaround because the echocardiogram revealed a moderate enlargement of the left atrium and an unstable vegetation in the left ventricular outflow tract, aortic thickening and regurgitation, a mild regurgitation, a mitral regurgitation, pulmonary hypertension, and a patent foramen navale. I'll put these results in the chat also to you so you guys can read. Besides, we then decided to proceed with a transesophageal echocardiogram that confirmed the mitral valve with vegetation in the subvalvular apparatus and associated with a calcification and also the regurgitation that was present. And so by now we thought about some possible diagnosis, and we talked about the infectious disease team, and they recommended starting antibiotics and penicillin and ceftriaxone. And by this time, the blood cultures were negative, and yeah, that's it. So I'll stop here. And just to remind that it was very clear for us that we have like different problems. We had like the nephrotic, we had like the cervical mass, but we just tried to initiate the investigation with the hard thing.
Yeah, very interesting findings. As far as so with this echocardiogram and this, oh, we lost the screen for a second, but just, yeah, going off what you put in the chat, this enlargement of the left atrium, so pressures on the left side, maybe the mitral valve is stenotic and causing that left atrium to be enlarged and can be a nidus for all sorts of arrhythmias like atrial fibrillation. And then unstable vegetation at the left ventricular outflow tract. So this is interesting. With substance use disorder, bacteremia that's induced by that, usually you have right-sided endocarditis, but majority of the population will have left-sided endocarditis. So the left-sided endocarditis can be caused by many usual organisms. So it'll be imperative to, at least at this point, seeing that, do blood cultures. But what's very interesting, I don't see really a large signature or signal of infection in this patient. No fever, no hemodynamic instability. The white count wasn't, I think it was 3.8, so 3,000 wasn't even elevated. But we may be dealing with a different patient where they're expressing their inflammation through other means. Ferritin, the CRP was not elevated, but the ESR was elevated. So there are other means by which the patient could be expressing this inflammatory response. So I think at this point, definitely cultures would be the order of the day. And then probing further to see empiric antibiotics. If I had to talk about penicillin plus ceftriaxone, it's very interesting. What we're covering here with penicillin would be MSSA staph, obviously in the ceftriaxone gram-negative rods. But would there be a case for multi-drug resistant organisms? Not sure, unless this patient has had frequent encounters with the hospital system or previous history of drug-resistant organisms, or has previously been on antibiotics within the last few months. But interesting turn of events, and I definitely think we do need to work this up further. As far as lymph node And lymph node and endocarditis is that could indicate infection. Lymph node endocarditis nephrotic syndrome, and we haven't even gone to the labs, the kidney labs, to verify that we have nephrotic syndrome. I think we're talking about multi-system inflammatory syndrome, and with this vegetation, there's many different things. It could be a sterile vegetation too. So malignancy can cause morantic endocarditis. Lupus can cause Liebman-Sachs endocarditis. So there's many different kind of endocarditis that you can get that are non-infectious, but due to connective tissue disease. So those are a few thoughts that come to mind. What do you think, John? This is very interesting. Like what's being unfolding here.
Yeah, I'm right there with you. I was not expecting this vegetation coming out of left field and slapping us in the face here. But yeah, like the blood cultures being negative doesn't entirely exclude infectious, but I'm thinking about like, is this, Liebman-Sachs, could this be a clot? Different nephrotic syndromes do make you predisposed to clots because you're losing some of the necessary anticoagulant factors. So could this be linked somehow to like nephrotic syndrome in a hypercoagulable state, and there's a thrombus? But I'm still open to infection. I've seen some cases where ultimately the tissue, the culture, and pathology revealed a more indolent, slow-growing infection, but we're not seeing a really strong signal for that. I just have a harder time linking the neck mass with the kidneys to this vegetation on the valve, but open to it being a clot, open to this being manifestation of the occurrence of cancer. Could this all still be linked to underlying lymphoma? And it's so curious to see the urine and some additional workup with imaging. Anyone else in the chat have any other insight or open to more ideas?
Yeah, so perfect. I'll continuing the second problem that we like tried to figure it out was about the cervical mass and yeah, all the neurological symptoms. So we did a cranial and CT that also was a huge turnaround for us that revealed the fused lytic bone lesions on the skull. And we also did a chest CT, and the chest CT revealed bilateral pleural effusion, hydrostatic pulmonary edema, and osteodegenerative changes with both with sclerotic foci distributed in vertebral bodies that was suggestive of bone islands. And due to the pancytopenia, the patient received 3 blood transfusions during the hospitalization. And yeah, I think that's something we can discuss a lot about these findings.
Was there ever a peripheral blood smear done?
Yeah, that's I need to confess that both the UA and the peripheral smear, I don't remember that, if I took that from the chart. I'm sorry for that.
Oh,
That's
no
really
worries.
essential. My mistake.
No worries at all. Yeah, so it's with these lytic lesions, certainly thinking about a monoclonal protein is in our differential here, and certainly in some of my thoughts are about where to get tissue to make progress as well. So I think with the cytopenias and bony lesions, hypercalcemia, I think their bone marrow certainly needs to be investigated, which could be another potential way of unifying a lot of the features of the case, but not quite all of them. I don't have a good, my illness script for, myeloma hasn't included a neck mass or a vegetation in the heart, but the bone marrow certainly should be looked at. Or other, like what other things could have like a monoclonal protein, an SPEP with immunofixation would be important, but there could be other ways for that besides a multiple myeloma me in the chat brought up Castleman's disease, which can also cause a monoclonal protein and have kidney involvement as well. So that's a good rare diagnosis to think about too. Ravi, how else are you digesting this?
Yeah, I think you're absolutely spot on that we're dealing with many different organs, and then you have to sort of meander into the domain of multi-system disorders, and the landscape is vast. I mean, you touch on like Castleman's, there's many different syndromes, but you know what? Let's kind of stick to the basics. Yes, we have a flavor, you have a neurological disorder, or this, I don't know if the lymph node is causing this, but nerve, kidney, anemia, and then the calcemia, hypercalcemia, and so on. Does kind of have a flavor of a plasma cell dyscrasias, and there's so many different kinds that it may not just be multiple myeloma, but it could be light chain variants. So that we do know light chain disease can cause nephrotic syndrome. So just looking at this, if we take this new bit of information, there's the lytic lesions, the causes can be many. Obviously, for step one, we equate that with multiple myeloma, but certain infections can also cause it. Metastatic lesions can cause it. And then there's a couple of esoteric conditions, histiocytosis, and so on. So I'm just kind of wondering, but you know what? We haven't even gone to the nephrotic syndrome labs. I'm interested if we had to order all the labs. I mean, definitely SPEP, UPEP will be important. Definitely want to see what's going on in the bone marrow, but before that, let's at least look at the electrophoresis and see what we have there. And then at least get an HIV. HIV can manifest in many different ways, hepatitis, anti-PLA2R. We haven't even got the UA yet. So we need the UA before that. I know people are screaming like, give me the urine, so we can look at how much protein is in there, get a urine protein creatinine ratio, because you have albumin creatinine ratio, urine protein creatinine ratio, and urine protein creatinine ratio will be much better because it would also involve other proteins other than albumin as well. So I think this will be very important. And then you get renal ultrasound as well, and start with that, and then bring in all this other data once you at least decipher that we're dealing with nephrotic syndrome.
So, all right. The serologies were negative, both HIV, Hep C, Hep B. Let me see what more. So we tried to have a beta-2 microglobulin that came high, and we also have a urine protein electrophoresis that showed a monoclonal and protein detected that was positive for kappa. And so we also had a bone marrow biopsy that showed the presence of 38% of plasma cells. I'll stop here.
Yeah, very, very interesting. Yeah, so it's kind of the instinct is to think, we've got these like 38% plasma cells, but a lot of atypical features if we're considering the possible the diagnosis of multiple myeloma. But also like thinking about, could there be some other plasma cell dyscrasia that's involving the marrow, and trying hard to link this with the neck. Ravi, where's your head?
Yeah, I think we were kind of thinking of plasma cell dyscrasias, and against the landscape is quite vast. I mean, you have obviously multiple myeloma, and Waldenstrom's macroglobulinemia, light chain disease, and I guess typically this we did see mainly a kappa, so positive for kappa in this case. So I think we may be dealing with light chain associated disease. And yeah, this would actually give you it could manifest with um, lymph node or lymphadenopathy like this. Sometimes you can have neurological associated dysfunction as well. You can have, although I'm interested about it causing masses or this vegetation in the heart, that I'm not quite sure about. But definitely this can be a cause for kidney disease, especially with proteinuria. I guess once they do the urinalysis, it will be quite vast. But at this point, yeah, I would like to see like what Vinny has for the next aliquot. Any other thoughts, John, before we continue on?
Well, yeah, I think it's a challenging and complex case. So just want to acknowledge that, and yeah, I'm ready to get the next bit of information. Maybe some probably potentially tissue at some other site too to help gain clarity. Maybe where I'm looking to make progress, confirmation of a diagnosis.
Yeah, so now I'll review the diagnosis, and due to the large spectrum of clinical problems, we try to divide and about the vegetations that we saw, we tried to see if the patient like had the Duke criteria, but the patient will just had like one major criteria that was the lesion on the echo, and one minor criteria that was the predisposing heart condition. And even though we decided to to start the antibiotics, and the patient is until now with the antibiotics, so we're like keeping the antibiotic treatment. We also had this chronic kidney disease that like it's came in from moms, and these high uptrending creatinine. And yeah, I'm really sorry for the I'm not in the chart right now. I would consult it. And the third diagnosis, we discussed it about the possibility of a plasmacytoma or an multiple myeloma, because the monoclonal peak of the M protein was not like that high, was not so characteristic. That in conjunction with the other findings, with the plasma cells that was in that was present, and all the lytic lesions, the renal involvement, and the kappa positive. In the kappa positive, we had the diagnosis of multiple myeloma. And one thing that was interesting for me that by this point is that it was decided to not treat at least the multiple myeloma right now, because the patient is suspectably in infection. So the patient is in treating for a yeah for the vegetation. And so we hold, and we hold the treatment for the multiple myeloma. And yeah, so we're just waiting for that right now, and see how it goes with the vegetation. And we are trying to repeat the transesophageal echo, and see when we can start the treatment. Yeah, I don't know if it's very clear, the case. Yeah, that's all, guys.
Yeah, yeah. What I'm understanding, so we definitely have a diagnosis of multiple myeloma, and this patient, if you think about it, has immune dysfunction, right? So the patient is at risk for many different kinds of infections. So this endocarditis may have nothing directly to do with it, so but indirectly, so this patient is vulnerable to any numbers of different infections. And like John had mentioned, in spite of the blood cultures being negative, you can have infections. And nowadays, even doing you have these PCRs that can be done biofire and so on, can expose some of these underlying infections, like the HEC group was mentioned earlier. So we were able to diagnose these at a much better rate than we used to. So I think that the endocarditis is not a direct effect, but maybe an indirect effect. Yeah, what came to mind are these poems people were always mentioning, and I was thinking because we didn't really integrate the thyroid dysfunction. So we have thyroid dysfunction. We have a single lymph node though, but usually with poems you have lymphadenopathy. I would anticipate it being more diffuse. Polyneuropathy, is this a polyneuropathy? I'm not sure. It's more of a hyperalgesia, but you could say, okay, the arm polyneuropathy, the lymph node organomegaly, endocrinopathy, monoclonal. We don't have a skin change. But that's something interesting to visit because I've had one time, probably 2 years ago, a POEMS syndrome case on CPS. So it's very infrequent and not something you commonly diagnose. But I'm very happy that we at least able to get to around multiple myeloma and plasma cell dyscrasia as a cause of this patient's presentation. What do you think, John?
Yeah, because I've yet to see a poem syndrome in person, from those things that continues to come up on morning report. So certainly have like some of the features, and maybe, you know, so if you're somebody who's read more about it, could say like, is there like an association between, you know, myeloma and poems syndrome? Are they known to be, you know, associated, or like myeloma being a potential trigger for it?
Yeah, I think the one underlying the test, I remember it was Dr. Sanjay Patel, Ohio Riverside Health, right? So they present, if you go back to their program morning report they presented. So they had taught us that VEGF levels would be prominent in this. So a VEGF level being elevated would help you make this diagnosis. So you made a diagnosis through the elements. You got the bone marrow biopsy, high, like greater than 10% of plasma cells. You got the SPEP, UPEP, and so on. And then you have all the other things like organomegaly and the neurological component and skin changes and so on. So the VEGF would be very important. I think the VEGF probably is the driving force. If I remember, VEGF could cause a number of things. The blood vessels, it can affect the blood vessels, can affect coagulation, it can affect vascular permeability, it can cause bone-related issues, and also, interestingly, this patient has pulmonary artery hypertension, so it can also cause that too. So I think VEGF level will be helpful. I don't know if Vinny did get one.
Yeah, so I'm sorry again.
Oh, VEGF level.
Oh, I'm sorry. I don't have that, Ravi.
But yeah, now I'm very interested. If you get a VEGF level,
Ah,
will that make a POEMS diagnosis in this case?
perfect. I'll ask for that.
And I think like this, just acknowledging that this case is a lot of just, this is a lot of times how reality is. There's not always a clear diagnosis wrapped up with a bow at the end. So appreciate you bringing you know, a dose of reality to a morning report, in a way of speaking. Um, the hyperferritinemia is still kind of me a little bit too. I mean, could still like a malignancy be a trigger for an HLH cascade of inflammation with the lymph nodes and some of the other features of the case? And sometimes it's hard to say with, you know, total certainty, like this vegetation, is this a thrombus and just kind of related to a underlying hypercoagulable state from a diffuse malignancy? It'd be something I'm still thinking about too. And I don't know if this is still like an ongoing, process. If some tissue from the lymph nodes might be helpful too.
Yeah, I think if we boil it down to the basics, you had already mentioned inflammation, right? And I think also renal failure can accentuate this level. So it may just be a signal for inflammation plus kidney failure, also accentuating the level. So yeah, we tend to, every time I see hyperferritinemia, we get excited with HLH, but not every hyperferritinemia is that. I mean, there's other conditions like hemochromatosis definitely could be a signal for this. Adult onset Still's disease. We actually had a couple of histoplasmosis cases where the ferritin is elevated, but here I think it's just breaking it down to its simplest form, an indicator of inflammation. And this patient is massively inflamed if you think about it, and many different systems and organs are involved. But I'm really interested if they get a VEGF level, if this is a case of POEMs.
Yeah, so I just want to thank you guys. That was a complex case because imagine that we are like we asked it, we just finding and one thing that we were not expecting at that point, and then we need to start thinking again and again and again, and yeah, so it was we had like a lot of turning points and teaching points also. So I really appreciated all the discussion.
Yeah, and same here, Vinny. Appreciate you bringing this really interesting case and allowing us to brainstorm. And John, thank you for coming on. And I know you're working and sharing your thoughts and teaching all of us as well with what you got from this case. I'm going to swing it over to Parisa, who will take it away with the teaching points. Thank you, Parisa.
Thank you, everyone. It was a great case, Vinny. Thank you. You are always surprising us with great cases and amazing discussion, Dr. Ravi and Dr. Black. We started with a patient who came in with a general malaise and edema. When we started with this discussion that usually edema and malaise are common manifestation and they can arise from various conditions. It results from either increased hydrostatic pressure or decreased oncotic pressure. Specific causes include hypoalbuminemia, nephrotic syndrome, protein-losing enteropathy. It could be due to liver disease or hypothyroidism, which usually presents with a peritibial edema. We learned that the time course and the duration of the edema can provide important diagnostic clue to us, and typically bilateral edema suggests a systematic issue versus a unilateral edema might be indicative of a vascular obstruction. Moving on, frothy urine symptom, we know that is usually pointing out to proteinuria, but sometimes it could be a sign of the pseudoproteinuria, sometimes a cleaning product in the bathroom. It could be present like that. It could be sign of dehydration or condition like the diabetes mellitus. We touched on the Lermit sign, which is characterized by electric shock sensation that travels down the spine, and it is usually rarely associated with multiple sclerosis. We also learned that in case of severe anemia, when hemoglobin drops to 6, but the heart rate remains normal, we usually considering chronic underlying process. It is happening in the background. We also learned how to manage hyperkalemia in the patient who are having renal failure because it is a really critical situation. We need to treat patient with some heart myocyte protective reagents like calcium gluconate. We need to shift the potassium into the cell via insulin or beta agonists. We need to enhance excretion using some loop diuretic or dialysis. We need to continuously monitor the patient with VEKG, and we need to request nephrology consult. We learned that for when we are assessing liver enzyme and AST is elevated more than ALT, usually this is showing us that we are having non-hepatic source for this elevation. It could be hemolysis due to alcohol abuse or rhabdomyolysis. We also talk about elevated ferritin level. Again, it could be seen in diverse conditions, including bacteremia, COVID infection, and it comes from complex scenarios like HLH or cancers. We also learned that when nephrotic syndrome accompanied with lymphadenopathy, the differential diagnosis it could be monoclonal gammopathies, HIV, or granulomatous diseases. We also learn about when we are treating empirically endocarditis, we need to use penicillin and also ceftriaxone to cover gram-negative rods. We also touch base non-bacterial thrombotic endocarditis or marantic endocarditis. These are typically associated with underlying malignancy or systemic condition like SLE or hypercoagulable states. We learned that usually bone lytic, we learn in the step 1, we learned that bone lytic lesions, cytopenia, and hypercalcemia raise suspicious for disease like multiple myeloma, but we need to keep in the back of our mind diseases like Castleman disease. Diagnostic tests could helping us are SPAP, UPAP, and immunofixation, and bone marrow biopsy. We learn about the urine protein creatinine ratio offers a comprehensive measurement in compare to albumin to creatinine ratio because it is measuring all the urine protein. We also talk about plasma cell dyscrasia, which is encompassing condition like multiple myeloma, which was our diagnosis in here, Waldenström, macroglobulinemia, and light chain diseases, which is presenting with disease, kidney dysfunction, lymphadenopathy, and neurologic symptom. Amazing discussion, everyone. I learned a lot today.
Thank you, Parisa. That was absolutely wonderful. It's as though you gave a lecture on plasma cell dyscrasias and the many features of this case. So I really appreciate you coming on and summarizing all the points. Thank you, everybody. Thank you again, John, for co-discussing. And Vinny, fantastic case. Keep bringing those cases and challenging us and teaching us. And thank you, everybody, for participating in the chat and logging on today. So have a great rest of your day. Take care. Bye.
Bye.